Welcome to the Deep Dive. Today we're plunging into a really surprising medical mystery, something that's actually making doctors rethink some pretty long-held beliefs about eye health.
Yeah, just imagine being told you have a serious eye condition, one that usually means immediate, urgent surgery to stop you from losing vision permanently. But then sometimes, incredibly, your eye just heals itself. How does that even happen? It's more than just a weird medical case. It feels like a genuine, paradigm shift.
Exactly. What we're talking about is spontaneous reattachment of rhegmatogenous retinal detachment.
Right.
SSRRD for short, thankfully.
Right.
So let's break that down a bit. Rhegmatogenous retinal detachment, or RRD, that's when the retina, the light-sensing part of the back of your eye, like the film in an old camera, it peels away from its support layer, the RPE. That's serious business.
Definitely.
And spontaneous reattachment means, exactly what it sounds like. It heals itself. No surgery involved. It's kind of mind-blowing, isn't it? Because, for context, a standard retinal detachment, RRD, you have to get that fixed fast. If you don't, you're looking at irreversible vision loss.
That's the standard teaching, absolutely.
But this SSRRD thing, it hints that the retina has its own intrinsic repair mechanisms, almost secret ones. And it wasn't even formally described until, 2007? That's pretty recent.
It really is, relatively speaking.
So our mission today is to sift through the research, try to figure out the what, the how, and the why of this, rare but totally fascinating condition. Give you the real scoop. Okay, so we get this amazing ideal, the eye fixing itself. But the obvious question is, how rare is this? Is it like a 1 in a million thing, or something doctors might actually see?
That's a great question. And honestly, the true incidence, it's still largely unknown. Partly because it is rare, but also probably because it's under-recognized.
Missed sometimes.
Could be. Early reports, like one key study, they only found 15 patients, and that was over a 12-year period. So yeah, initially it seemed incredibly rare.
Okay, 15 over 12 years. Sounds tiny. But has that changed? Has more recent research given us a clearer picture?
It has, somewhat. More recent data, especially from a larger study in 2023, they looked at 86 eyes. They actually estimated SSRRD might happen in about 2.5% to maybe 3% of all RRD presentations.
Wow, okay, 2.5 to 3% is still rare, but way more than 15 cases suggests.
Exactly. And there was another smaller study from Tunisia that kind of backed this up. They found it in 3.2% of their acute RRD cases, the ones that weren't immediately taken for surgery.
Right. So pulling that together, while it's definitely not common, these numbers suggest SSRRD might be, maybe a bit more common than we used to think. Especially in certain contexts, it's not quite a unicorn anymore.
Maybe a rare breed of horse, as you said.
Yeah. Okay, so it sounds almost miraculous. What are the specific conditions, the circumstances that seem to allow this spontaneous healing? Are there common factors in these cases?
Well, one thing that pops up a lot is high myopia, severe nearsightedness. Patients often have a pretty significant prescription, -5 diopters or even more. It seems like the structure of a highly myopic eye might somehow make this self-healing more likely.
Interesting. And what about the actual tear in the retina?
Usually the retinal breaks are quite small, often just a single one, like an atrophic hole, which is more like a wear and tear spot, or maybe a small horseshoe tear.
Right.
And critically, they're often peripheral, way out on the edges, away from the macula, that central part you need for sharp, detailed vision.
Makes sense. Smaller tear, less critical location, maybe easier for the body to handle.
That seems to be part of it. But here's something really surprising. The role of what's called persistent posterior vitreous attachment, or PVA.
Okay, explain PVA.
So you have this jelly inside your eye, the vitreous. Normally, as we get older, it liquefies and pulls away from the retina. That's called a posterior vitreous detachment, PVD, and it's common.
Right, I've heard of that causing floaters.
Exactly. But in many of these SSRRD cases, that attachment doesn't happen. The vitreous stays attached to the retina. One study found PVA in almost 44% of the SSRRD eyes. Compare that to only about 20% in typical RRD cases that need surgery.
Huh. That seems completely backwards. Wouldn't something pulling on the retina make detachment worse?
You'd think so. But that's the fascinating paradox here. It seems this persistent attachment might actually act like a sort of natural splint.
The splint.
Yeah, providing some mechanical support, maybe preventing the kind of pulling, the tractional stress that usually makes detachments worse or rips the tear bigger.
Wow. Okay.
And crucially, another factor is minimal proliferative vitreoretinopathy, PVR. That's the bad scar tissue response that can happen after detachment.
Right. The stuff that causes real problems.
Exactly. In SRRD, the PVR grade is usually very low, like grade A or B, which means there's very little of that aggressive scarring or pulling going on. Things stay relatively calm inflammation-wise.
So a combination of factors. And what about the patients themselves and their typical profile?
They do tend to be younger, often phakic, meaning they still have their natural lens, haven't had cataract surgery.
Right.
And generally, they have healthier eyes overall, fewer other eye conditions, no history of previous eye surgery. All this suggests maybe a more robust RPE, that support layer we talked about, and just a healthier interface between the vitreous and retina. It creates a better environment for healing, perhaps.
Like the body's repair crew is working efficiently without making a bigger mess.
That's a good way to put it. A neat, tidy job.
Okay, so we understand the what small peripheral tears, myopia, this weird, persistent vitreous attachment, minimal scarring. And we've touched on the who younger, healthier eyes. How does the eye actually do the repair work? What are the biological mechanisms?
Well, one key idea is the spontaneous closure of those small retinal breaks.
Oh.
It seems cells from the surrounding area, pigment cells from the RPE, maybe glial support cells from the retina itself, they can migrate over and proliferate, basically forming a natural patch or seal over the tiny defect.
Like plugging the leak.
Exactly. And there's actually histological evidence from studies looking at eye tissue under a microscope years ago, showing this kind of cellular sealing process can happen.
Okay, so the leak gets plugged. What about the fluid that already got underneath?
That's where the RPE really shines.
Yeah.
It has this amazing built-in pump system, an active fluid transport mechanism. Once the inflow through the break stops, the RPE can start pumping that subretinal fluid out back into the choroid layer behind it.
So it actively dries out the space.
Precisely, leading to the retina settling back down anatomical reattachment. And this pumping action seems to be more efficient in younger people and also maybe in those eyes with certain myopic changes where the RPE and choroid might still be functioning well.
Got it. And you mentioned minimizing traction earlier with the PVA.
Right, that's critical. If you don't have significant pulling forces or vitreoretinal traction, the break is less likely to get bigger or stay open, and new breaks are less likely to form. That persistent vitreous attachment paradoxically seems to help by keeping things stable, preventing that damaging traction.
So less pulling means the patch can form and the pump can work.
That seems to be the idea. There are also a couple of rarer things mentioned. Sometimes a choroidal detachment where the layer behind the RPE separates a bit might happen transiently.
Okay.
And that could potentially push the retina forward slightly, acting like a temporary internal tamponade, limiting how much fluid gets under the retina.
Like a little internal pressure bandage?
Sort of, yeah. And sometimes you might see very fine membranes forming on the retina's surface, epiretinal membranes, or ERMs, or even some mild scarring underneath called subretinal gliosis. These might also subtly help stabilize the reattached retina long term. It's like the body has multiple backup plans, some more effective than others.
Okay, so we've got the what, we've explored the how the body might be doing this repair. But thinking about the patient, what does this actually feel like? What are the clues a doctor might spot? Are the symptoms the same as a regular detachment?
That's a key difference. With a conventional RRD, you often get pretty dramatic, acute symptoms, right? Flashes of light, a sudden shower of floaters, a curtain coming across the vision. It's usually alarming.
Yeah. Sounds scary.
But with SRRD, patients often present with really minimal, often non-specific symptoms. Maybe just noticing a few more floaters than usual, those little specks drifting around, or perhaps some very mild visual distortion, things looking a bit wavy. It's much, much more subtle.
So subtle it might be ignored or put down to something else?
Exactly, which probably contributes to it being under-recognized.
And then when a doctor looks inside the eye, what does a spontaneously reattached retina look like? Is it obvious?
Well, the retina itself might look flat, reattached, but it often carries the scars of having been detached. You might see these sharply marked areas, often in the periphery, with pigment changes like faint discoloration or mottling.
Yeah.
Maybe a slightly curved or convex contour to that area, or signs that the RPE support layer underneath has thinned out a bit, what we call atrophy. The problem is these signs can easily be mistaken for other things, just chronic old retinal changes from myopia or maybe leftover marks from previous laser treatment.
So it's a diagnostic challenge.
It really can be. And this is where advanced imaging, specifically optical coherence tomography, OCT, becomes so valuable.
Right, the OCT. It gives you those amazing cross-section pictures of the retina layers.
Exactly. It's like an MRI for the back of the eye. OCT can often show subtle signs of past trouble, even when the retina looks okay on a surface exam.
What kind of signs?
Things like disruption in the outer retinal layers, the photoreceptor layers, the ellipsoid zone, the interdigitation zone. These are signs that those delicate cells were stressed when the retina was detached.
I see. Evidence of past trauma.
Precisely. OCT also frequently picks up those epiretinal membranes, the ERMs we mentioned, forming on the surface, nearly half the cases in some studies, and also signs of that subtle scarring underneath, the subretinal gliosis, in over half the cases. These are all clues that a healing or remodeling process has occurred.
Okay.
And there's a specific, maybe more problematic variant of ERM called atypical epiretinal tissue, or AET. When that's present, it seems to be linked with worse visual acuity outcomes.
Worse vision even though it reattached.
Yes, particularly in older patients or where the original detachment was larger. It really makes you think. Just because it's anatomically reattached, does that mean the vision is fully recovered? Not always.
Which leads us nicely into diagnosis and management. What are the go-to tools for clinicians, and how do they decide what to do once they suspect SRRRD?
Well, fundus photography, taking pictures of the back of the eye, is useful for documenting those characteristic pigment changes and the demarcation lines that show where the detachment used to be.
Okay, documentation.
But really, the absolute cornerstone investigation is OCT.
Why is OCT so central here?
Because it's just so good at picking up those subtle clues we talked about. The disruptions in the layers, confirming there's no fluid left underneath, spotting those ERMs or the gliosis. And importantly, recent studies have shown that the OCT findings strongly correlate with both the anatomical outcome, how well it reattached, and the functional outcome, the final vision.
So it helps predict how things might turn out.
To some extent, yes. If the media, like the lens or vitreous, are cloudy, then B-scan ultrasonography can be helpful to see the overall shape and confirm reattachment. And occasionally, other imaging like OCT angiography might be used to rule out other problems, but it's not standard for SRRD itself.
Okay, so you use these tools, you suspect SRRD. What's the management plan? It's clearly not always rushing to surgery like a typical RRD.
No, it's much more nuanced. It really has to be individualized based on exactly what the clinical exam and the OCT show. Observation is often a perfectly appropriate strategy.
Watch and wait.
If the retina is fully reattached, if the break looks sealed or scarred over, and crucially, if the patient's symptoms aren't getting worse, then yes, watchful waiting is often the first step.
But that must require careful follow-up.
Absolutely critical, close follow-up, especially in the first 6 to 12 months. That's the period when there's the highest risk of it redetaching, or maybe one of those ERMs developing and becoming visually significant.
Makes sense. It sounds almost too good to be true, though. Are there risks to just observing instead of operating right away?
That's the key question, and why monitoring is vital. While surgery is often avoided, it's not off the table completely. Sometimes prophylactic laser treatment, laser retinopexy, might be considered.
To kind of tack down the edges?
Exactly. To reinforce the adhesion around the area of the original break, especially if you can still see a specific residual break, or maybe if there are concerns about whether the patient can reliably attend follow-up appointments.
Okay, so laser is an option sometimes. When would actual surgery be needed?
Generally, surgery is reserved for specific situations. If the detachment involves the macula, the central vision area, or if one of those ERMs becomes symptomatic, causing significant visual distortion, or, of course, if the retina simply redetaches.
Right. It's interesting you mentioned earlier studies where patients didn't have surgery and stayed stable.
Yeah, in that initial large series from Cho et al., none of the 15 patients ended up needing surgery, and their retinas remained attached over the follow-up period, though, importantly, their final visual acuity varied quite a bit.
And the more recent studies?
Similar findings mostly. Sun et al.'s larger study reported most eyes kept their structural integrity over about 25 months. But, and this is a key point, those eyes that had that atypical epiretinal tissue, the AET, or significant disruption of the outer retinal layers on OCT, they had significantly worse functional outcomes. Poor vision.
So anatomically stable doesn't always mean functionally perfect. Okay, so wrapping this up, what's the big takeaway message for you, our listener? I think the enduring message here is that SRR, it's a distinct clinical entity. It might be under-recognized, but it genuinely challenges that conventional wisdom about needing urgent surgery for all retinal detachments.
Yeah, zooming out, it seems to be characterized by a specific set of factors, right? Those small, often peripheral retinal breaks, minimal pulling forces on the retina, often high myopia, and frequently that persistent vitreous attachment. It suggests that in certain eyes, the biological conditions are just right for it to resolve on its own. That's a powerful insight into natural healing.
And looking forward, the future of care seems to involve careful clinical assessment, definitely relying heavily on OCT imaging, and then using prudent observation for selected cases. It means potentially avoiding unnecessary surgery for some people.
But these eyes absolutely need close monitoring to make sure things stay stable. You can't just diagnose it and forget about it.
Definitely. And maybe here's a final thought to chew on. We've seen that anatomical stability, the retina being back in place, doesn't always equal optimal functional recovery. Vision might not be perfect.
Right.
So what does that tell us about the complex link between how our bodies physically heal and how we actually experience that healing, how well we function? And maybe even more broadly, what could further research into SRRD tell us about the body's amazing, sometimes hidden capacities for repair, not just in the eye, but maybe elsewhere too?